welcome. My name is Justin Lorentz. I'm a genetic counselor, and I work with the PROMIS Registry. Today, I'm going to chat with you a little bit about cancer, genetics, and how both of those things are connected to prostate cancer. Today's agenda is going to focus on do a bit of a genetics 101, a cancer 101, why your genes matter in this prostate cancer story. We'll talk a little bit about how genetic testing can lead to targeted therapies. I want to focus a little bit on the PROMIS Registry and why a registry like this might be right for you. And then we'll have an opportunity to do some questions and discussion afterwards. So our team consists of three major groups. The first is this organization or company called Color Genomics. And they're a genetic testing company. So we work with them to do genetic testing. We also work with the Prostate Cancer Clinical Trials Consortium, as well as with ACT, or Advancing Cancer Treatment. And so these three kind of entities have helped create this PROMIS program. And our team of experts includes Dr. Heather Cheng, Dr. Channing Powler, myself, and Jake Vinson, to give a little bit more insight into genetic counselors. We'll talk a little bit about what we do in the presentation. Essentially, my job is to coordinate, discuss genetic testing, discuss genetic test results, implications for what a genetic test result could have for an individual, as well as implications for what a genetic test result could have for a family. In this presentation, however, I want to give some overview about what genes are, what cancer is, how genes relate to cancer, and then I want to talk a little bit about how your genetic status could impact treatment. I want to talk more about the PROMIS Registry and how it could have implications for an individual and whether or not this might be a registry that would be right for you. And then we can have some time for questions and discussion afterwards. So let's start with genes and cancer risk, why your genes matter in the prostate cancer story. So when it comes to genes, really, genes are present in every cell, and our body is made up of billions and billions of cells. Genes are very long pieces of DNA. They have instructions that tell our body how to grow. They have instructions that tell our body how to function. Each gene really has a job. And for the purposes of this discussion, I want to focus on the genes whose job is to protect us from cancer. Some of the genes that are most well-known are the genes called BRCA1 or BRCA2. They're oftentimes called BRCA1 or BRCA2. And so I might use them as examples throughout this presentation because they're pretty well established. But there are many genes that are connected to prostate cancer or really other types of cancer like breast cancer, ovarian cancer, pancreatic cancer that the PROMIS study analyzes and follows people for, like ATM, CHEK2, MLH1, MSH2. But again, I'll focus on BRCA1, BRCA2 for this talk. So genes can have mistakes or mutations in them. Most genes don't. Most genes are perfectly healthy and perfectly fine, but there are a few people who have mistakes and mutations in these genes, and these are mistakes and mutations that are either acquired over someone's life. For example, if someone gets a sunburn and their skin kind of flakes off, it's because they had UV radiation exposure to their skin, causing mutations, and the skin comes off. These are acquired mutations. Oftentimes, the body's very good at dealing with cells that have damaging acquired mutations. There are also mutations that we can inherit from one generation to the next, from our parents. We inherit these from cells like sperm and eggs. We call these sex cells or germ cells. And if someone has a mistaken mutation that they've inherited from their mom or their dad, when they have children, they could pass on these mutations as well. So the process of passing on a genetic mutation looks kind of like this. So here I have a picture of a female. She has two copies of a gene. They're holding hands because genes come in pairs. We get one copy of our gene pair from mom's egg, the other copy of our gene pair from dad's sperm. When the sperm fertilizes the egg, we have two copies of each gene. Both of her copies are working just fine. The male, however, has a mistake or mutation in one copy. That's denoted by the red at the bottom. Now, when they go on to have kids, that female is going to pass on either one copy or the other of her working genes, but it doesn't matter which copy she passes on, they're both working just fine. The man, however, there's a 50% chance he's going to pass on the copy that has no mutation, a 50% chance he's going to pass on the copy with the mutation. And so it's a 50-50 whether or not his children will inherit that genetic predisposition. Now, if this is a gene mutation in a cancer-protecting gene, then that man's at elevated risk for certain cancers. There's a 50% chance he'll pass it on to his children. 50% of his children will be at risk for a genetic condition. If his child do not inherit the gene mutation, then they're not at elevated risk. When it comes to cancer, most cancers are not due to a genetically inherited predisposition. Most cancers happen by chance or because of minor genes that slightly increase risk. It's too complex for us to understand at this time. Based on what we know about cancer genetics that we can test for, only about 10% of people have an inherited genetic predisposition to cancer that we can detect, that they've inherited from either mom's egg or dad's sperm. We call these germline genetic mutations. Germ, because they come from germ cells, which are sex cells, like sperm or egg. Now, all cancers are genetic, but most cancers happen because of acquired mutations throughout someone's life. All cancer cells start as a healthy cell that accumulates a mistake or a mutation, either through the process of the cell just dividing naturally, and a mistake happens there, through environmental exposures like smoking or UV radiation, in these random occurrences where mutations happen, sometimes the immune system can get rid of them. Sometimes these cells with mutations can evade the immune system, and they would start dividing uncontrollably. They forget to be a prostate cell. They start being selfish. And as they're dividing, more mutations happen within this tumor, and we get multiple mutations that are forming, and this tumor is evolving into a cancer. And maybe some of these colonies of cells with mutations can attract more blood vessels so that the tumor can grow even more. And then maybe some of these little clusters of cells can evolve to detach and move to other parts of the body. So that's the natural process for which cancer happens, an accumulation of acquired mutations in a healthy cell that cause it to become cancerous. People who have a genetic predisposition or an inherited predisposition, this process just might happen a little bit faster. And so we can see cancer risks elevated in these people. So how can we test to see if someone has a genetic predisposition to their cancer? Well, we do that through genetic testing. And I want to talk about two different types of genetic testing that's out there. The first type of genetic testing is the type of testing that PROMIS does. It's germline testing to see if you have a genetic mutation that you inherited from mom or from dad that may account for why cancer happened. We can do genetic testing this way by analyzing any healthy tissue, whether it be a skin biopsy, a blood sample, or a saliva sample. It doesn't matter, as long as we're testing a healthy sample. When it comes to easily facilitating genetic testing, saliva is easy. You spit into a tube, you send it off, and we can get a genetic test result. Taking a skin biopsy causes a scar, and you need a doctor to do it or a nurse. Getting a blood sample, you need someone who's going to draw your blood. It's not easy stuff you can do from home. Spitting in a tube, you can do from home, so that's the way that we do it, a saliva sample. And if the saliva sample comes back and we see the genetic test result shows there is a genetic mutation there, and we say, this person has that gene mutation not only in their saliva sample, but in every cell in their body. They inherited that from mom or from dad. They were born with this genetic predisposition. If they have cancer, then we can say, okay, well, that cancer definitely has that mutation as well. So maybe there could be treatments that we use that target that specific genetic mutation. If there is no gene mutation, then we say, oh, okay, well, maybe that person's cancer happened for other reasons. Now, the other way that we do genetic testing is to test the cancer itself. So we'll take a biopsy or a sample of the cancerous tumor and analyze all of the mutations that are present. And there's going to be a lot of mutations present because, as we know, cancers happen through accumulation of mutations. And then the doctor will analyze all of the gene mutations present in that tumor and say, hey, do I have any treatments that target any of these gene mutations? And they can help them determine treatment options. So Promise does the saliva testing for the germline to understand if we have an inherited risk or an inherited reason for why we got the cancer that we did. So how does this testing work? Like I said, we can use any tissue. We can use blood or saliva, but to easily facilitate testing, saliva is easiest, and that's what the company that we use, Color, is validated for. So we get people to spit into one of these tubes. They send that sample off, and the scientists will basically read through the genes like they read through a book, line by line, page by page, looking for spelling mistakes or mutations. And if they find any, we get that information back, and we have a discussion about it. So when does genetic testing typically fit into a person's medical journey? Well, when you look at a patient's journey, it usually starts off by an individual being screened. Oftentimes, prostate cancer doesn't have symptoms. And so when someone gets their PSA testing or they have a digital rectal examination that looks suspicious, you might do a diagnostic test, a biopsy. And in that case, their doctor might be sending off the screening tests. They might have a doctor that's part of their diagnostic journey. And then if there is a diagnosis, there's a discussion about treatment, whether that be surgery, radiation, active surveillance, hormones, chemotherapy. And really, a genetic test result can help give a healthcare provider insight into which route we go. And so that's where the genetic counselors pop in, and that's when genetic testing may be an option for a part of a person's healthcare journey. So a genetic counselor fits in right around here, and a genetic test result can help inform treatment decisions. So how can genetic testing lead targeted therapies or treatment decision-making? Well, there's an interesting study that came out a few years ago that really changed the way that we look at prostate cancer, particularly metastatic prostate cancer, or prostate cancer that's spread to other parts of the body. The study showed that 1 in 10 people who have metastatic prostate cancer have a genetic predisposition that they inherited from mom or from dad. 1 in 20 people who have less aggressive, more localized prostate cancer have a genetic predisposition that they inherited from mom or from dad. And the bulk of these genes are genes like BRCA2, BRCA1, ATM. Well, it just so happens that there are targeted treatments for individuals who have ATM, BRCA1, BRCA2 gene mutations. There's a medication or a drug called a PARP inhibitor that basically takes advantage of the pathway with which cancer occurs in people with these gene mutations. And so really it changes a bit of the paradigm. Typically when it comes to cancer treatment, before we started looking at genetic predispositions, we kind of thought, okay, well, there's a group of people, we give everybody the same therapy, and what's interesting is that people have different outcomes. And if we're able to group these individuals and get more insight, we may be able to predict whether or not a medication might work better for someone, or predict whether or not a medication might not work for someone, or maybe it might work worse. And one of these things that could help us get that insight is genetic test results. If I can say, well, 1 in 10 people who have metastatic prostate cancer would have a genetic predisposition, then let's personalize their therapy to say they should be getting this, and maybe their outcomes will be much better. And this same therapy may not work on another cohort of people. The type of therapy that we would maybe offer someone who doesn't have a gene mutation would be different than the type of therapy that we would offer somebody who does. have a gene mutation. So this might help. Genetic testing can help personalize someone's medication if they have a gene mutation. If they don't, then it may not be super insightful, at least not at this time. But if someone's involved in something like a PROMIS registry, there may be other opportunities to do genetic testing in the future. If new genes become identified, that could maybe inform therapy in the future. So what is PROMIS? PROMIS is a prostate cancer registry that looks at how men do when they have germline mutations in terms of their survivability, and we're figuring out ways to improve survival, as well as how men do in terms of effectiveness of treatment. So it stands for the Prostate Cancer Registry of Outcomes and Germline Mutations for Improved Survival and Treatment Effectiveness. A huge mouthful, so we shorten that down to PROMIS. A registry is basically a collection of people who have one thing in common. And for PROMIS, there's actually two things that people have in common that we're interested in. One, the person has a diagnosis of prostate cancer. And the second is that they have a germline or inherited genetic predisposition that may have caused their prostate cancer. Now, even people who don't have that genetic mutation, if they've gone through PROMIS and had genetic testing and the results came back negative, those individuals may still be really helpful to advancing research for two reasons. One is that they could be a control. We could use the individuals who test negative to compare to people who are positive and basically say people with and without gene mutations, how do they do on management? That's a very important piece of information. The other thing is that people who test negative today may not test negative if they do more advanced testing, looking at different types of genetic predispositions in the future. So even if someone tests negative, still valuable, but people who test positive for some of these gene mutations, currently there might be some applications that we can do to impact treatment. This is a collaboration between doctors, researchers, and patients. Everyone's working together in order to kind of move our understanding forward. Our goal is to use this big pool of people who have these things in common as a foundation to help facilitate research. And the way that we do that is through, well, we'll talk more about how the process works. But we have educational materials. If new studies become available within the registry, we'll let people know about it. We keep people up to date with what's going on in terms of research and how we're doing in collecting the individuals that we need in order to get the numbers to be able to do some of our research. More than 4 million American men are fighting prostate cancer. For many of these individuals, there's a genetic predisposition that may have caused it. With that, there may be treatments that are better for understanding that individual's risk, not only for themselves, but for their families. We'll talk a little bit more about that as well. So how it works: you sign in online, you work with your family doctor or any doctor to facilitate this testing. You'll fill out a consent form, an online application to give some of your demographic information, and then you'll get a DNA kit shipped to you. That is a saliva tube that you spit into, send it back, and all of this is free. It's a clinical genetic test. It's a medical genetic test. And when we get those results back, you meet with a genetic counselor to discuss what that genetic test result is to help make that kind of technical report make sense, talk about some of its limitations, and talk about some of the information that it can provide. So that's where the genetic counselor pops in. And when it comes to color and the process of genetic testing, genetic counseling is optional. And I always strongly encourage individuals to meet with a genetic counselor, even if the result is negative, to get insight into the implications for that for their care, because there's always something to talk about, particularly if someone has a family history of prostate cancer and they have a negative result. So our job is to basically make genetics a little bit more easy to understand, talk about what the implications of a genetic test is for the individual person instead of these broad strokes that I'm giving now, For some people, it can help with decision making, particularly for treatment or management, or how to talk to their doctor about something that's identified in their genetic testing. If someone has a genetic predisposition to cancer, it may have additional implications for them. Some genes not only are connected to prostate cancer, but maybe to colon cancer or pancreatic cancer or breast cancer in men. If someone passes on one of these genes, it could have implications for the next generation or for siblings, particularly females. Breast cancer risk may be elevated. Uterine, ovarian cancer risk may be elevated in people with these gene mutations. So how to discuss this with the family and how to explain how these test results could be or how additional genetic testing can be done in family members. So when we people who are interested in being involved in PROMISE, we register online, provide a saliva sample for testing. Again, it's not tumor testing, it's germline testing, looking to see if there's inherited genes. All this can be done from home. You keep your existing doctor, and the whole process is done for free. The benefits of doing this is that we get genetic insights. You meet with a genetic counselor for free as well. There is information potentially that could impact treatment options. You'll get updates constantly on prostate cancer and genetics in prostate cancer. And maybe by contributing to the registry and having this genetic insights, there may be options for us to improve future treatments. If we more people that we can have join the registry, the higher the chance that we'll be able to do research that can make impacts. And that's our goal, is to be able to select as many people who have these things in common so that we can facilitate the research that needs to be done in order to answer some of these tough questions, such as whether or not these gene mutations could be impacting treatment and management in individuals. And maybe even to say, hey, if a big chunk of people don't have any of these known gene mutations, maybe there's other genes out there that we should be analyzing. And who knows, maybe in a few years from now, we'll be reapproaching and doing a whole new slew of genetic tests based on new knowledge that we have. That's all that I want to talk with you about. If there's any questions, I'm happy to take them.